Okay, airway management, chapter 7. Two of the most important life-saving skills are taken care of in this chapter: airway care and rescue breathing. ABCs of life-saving skills is airway, breathing, circulation. Always remember airway, breathing, circulation. ABCs fail, we need to take action quickly in order to maintain life. Okay, to maintain life, all humans have to have food, water, and oxygen. The lack of oxygen, even for a few minutes, can result in irreversible brain damage and death. Brain cells start to die at about 3 minutes without oxygen. Within 4 to 6 minutes of lack of oxygen, brain cells are dead irreversibly. They're not going to replace themselves. The main purpose of the respiratory system is to provide oxygen and to remove carbon dioxide from the red blood cells. As I said in an earlier chapter, we have a carbonic drive. We breathe to get rid of carbon dioxide. Carbon dioxide buildup in the body causes acidosis, and it causes the brain to start swelling when there's too much carbon dioxide on the brain. All right, we're looking at the respiratory system. Upper airway consisting of nasal cavity, mouth, nasopharynx, oropharynx, pharynx, epiglottis, and larynx. Larynx being your voice box. Upper airway, things like laryngitis, pharyngitis, things like that. Allergic reactions, anaphylactic shock, swelling in the throat, those type of emergencies. Lower airway, we're looking at the bronchioles, lungs, alveoli, and the circulatory system included or involved in the lungs. In an unconscious patient lying on the back, passage of air through both nose and mouth may be blocked by the tongue. In fact, in an unconscious patient, most of your airway obstructions is caused by the tongue. The tongue can't be swallowed. However, the muscles that control the jaw and the tongue, when you're unconscious, can become relaxed, causing a partial or a complete airway obstruction, often producing wheezing or snoring sounds, or sounds like stridor, which is a partial airway obstruction. Stridor is a high-pitched sound, usually while breathing in. Okay. There's a couple of pictures here quickly. You can see the muscles in the jaw become relaxed. The tongue falls back, blocking the airway completely. All right. Other parts of the respiratory system at the back of the throat, there's two passages, the esophagus and the trachea. Trachea is obviously the front part where we breathe through. Esophagus is the throat where we swallow our food to go down. The epiglottis prevents food and water from entering the airway. Okay, if you want to know a little bit more, the epiglottis is attached and hinged on the hyoid bone, the small cartilaginous type structure that keeps the epiglottis in place and it keeps it moving up and down. The airway divides into two bronchi, and at the end of each of these, there's a lung that is on either side of the heart. Okay, other objects in the parts, should I say, of the respiratory system, there's smaller airways called bronchs, going to bronchioles. Bronchiole end in tiny little air sacs called alveoli. Okay, alveoli has a myriad of little vascular system, fine veins, fine capillaries, capillary venules, and here's where you have your carbon dioxide and oxygen moving in and out of the lungs and into the bloodstream, usually by osmosis, moving from a higher concentration to a lower concentration. The amount of air pulled into the lungs and removed from the lungs is 1 minute, is the minute ventilation. Okay. There we go. Just a picture of the little alveoli with the arteries and veins and capillaries that are in this and where the gaseous exchange is taking place. All right. Lung consists of soft, spongy tissues with no muscles. Okay. The movement into the lungs depends on the movement of the rib cage. Lungs don't have muscles. They can't move by themselves. The rib cage is there to support it. They have muscles between the ribs called intercostal muscles. the diaphragm sitting underneath the ribs, the costal arch. Okay, when the diaphragm contracts, it pulls down, forcing air into the lungs. When it contracts again, okay, it forces the air out of the lungs. Okay, it contracts during inhalation and flattens and moves downwards. On exhalation, the diaphragm relaxes once again and the air is forced out the lungs. Remember, we don't breathe constantly. It's not in and out like that. Well, there's a rest period between inhalations and exhalations. Okay, so we don't breathe at 60 breaths per minute. We only breathe at 12 to 20 breaths per minute. An average adult at rest. Obviously, babies and infants breathe a lot more. Their lungs are a lot smaller. There's a picture of the diaphragm contracting, pulling down, and forcing the lungs to expand. The diaphragm relaxes and pushes up, and it forces the air out of the lungs again. This is the normal active breathing, normal mechanism. Okay, A is for airway. In healthy individually, the airway automatically stays open. Only when we're swallowing that it becomes closed. An injured or seriously ill person cannot protect an airway and it may become blocked. You must take steps to check the airway for problems and things like that. Okay, when we arrive on scene, we're doing our primary surveys. Okay, if the patient is unconscious, we always must ask the patient, or if the responsiveness is low, we ask, hello, how are you? Are you okay? Can you hear me? Sometimes we need to do a sternum tap, rub, or a shoulder tap, or to try and establish levels of consciousness. Okay, if there's no response for a patient, or if you're unsure, always get help. Your local responder, your local ambulance service, if you're in the States, 911. If you're in the UK or places like that, 999. Okay. If you're phoning from a cell phone in South Africa, 112, or if you know your own preferred choice of private ambulance service, then you would contact them quickly. We quickly turn the patient's chest for breathing movements. Remember, inhalation and exhalation, one movement, one breath. In, the chest expands, out, the chest decreases. That is one. If the patient has no pulse, is a pulse but not breathing, we need to correct the airway. Sometimes if a patient is unconscious and the airway is blocked and there's not able to breathe on their own, simply by opening the airway or correcting the posture of the head, the airway opens and the patient starts to breathe naturally on their own. Correcting a blocked airway, we always use the preferred way of doing things is called the head tilt, head tilt, chin lift maneuver. The patient is on her back, his or her back. Place one hand on the patient's forehead and firmly apply pressure backwards. Place two tips of your fingers underneath the patient's joint wall and lift the patient's chin and tilt the head backwards. If we lift the chin and tilt the head backwards, you will find the head moves back, the airway becomes a straight line, and it is open, and air can move freely in and out of that airway. If we suspect a spinal injury or neck injury and things like that, or a head injury, you suspect spinal injuries, we always try and use a jaw thrust maneuver. The jaw thrust maneuver is not particularly easy to perform. There are certain dangers in using the jaw thrust maneuver, and always remember that you will need more than one person to facilitate breathing with a jaw thrust maneuver. Okay, with the head tilted slightly back in a neutral position, place your thumbs on the patient's cheekbones, fingers under the jaw, and gently lift the jaw up towards you or whatever. Open the jaw, enough for breathing. Okay. Always look for potential blockages when opening an airway. Secretions like vomit, mucus, blood, foreign objects. If it's a child, a baby, an infant, any sort of toy that can go into the mouth, things like that can cause choking. If it's a child, candy, dirt, food, things, older people, false teeth, dentures. It could also be in a traumatic environment, things like teeth, tissue, things like that. If you find something in a patient's mouth, try and remove it. Always remember to avoid putting your fingers in a patient's mouth. It can be exceptionally dangerous. If you can't see something, don't stick your fingers in unnecessary. You may just be forcing those obstructions deeper into the throat. If the mouth is clear, we might want to use an adjunct or an airway device. Okay. When we're doing finger sweeps, it can be done quickly, require no special equipment, except a set of decent set of gloves. Suctioning helps to remove debris from the mouth, saliva, and tissue. Okay, the suction device could be a manual suction device. They're relatively expensive. Just a bulb syringe, a large bulb syringe with a spout could help if you're in a pinch. Okay, otherwise you get manual suction devices, you get battery operated suction devices, and obviously electrical ones. With a mechanical suction device, clear the patient's mouth with your finger, gloved finger, turn on the suction device, use a rigid tip to remove material. Do not suction for longer than 10 seconds. Okay, for a child, 10 seconds, and for an infant, no longer than 10 seconds. Change to a flexible clear tip and clear out deeper parts of the patient's throat. There's other things to remember that are very important with the suctioning. Only suction under direct vision. In other words, what you can see. If you can see it, you can suction it. You can't push the tip further down the patient's throat, hopefully trying to suction things. 9 times out of 10, you're going to end up pushing that thing in deeper, and you're not going to get it out. Okay, that's number 1. Number 2 is when you suction, only suction while withdrawing the tip or the catheter from the patient's mouth. Never suction going into the patient's mouth. Number 3, and also important to remember, don't overstimulate the gag reflex. Don't overstimulate the vagus nerve in the back of the throat. Okay, all of these things, one can lead to vomiting, the other one can lead to a drastic decrease in blood pressure and a slowing of the heart rate. Can be very dangerous for the patient. So remember, time, only for the recommended time, 15 seconds for an adult, 10 for a child, 5 seconds for an infant. Only what you can see, in other words, under direct vision. Okay, only suction while withdrawing the catheter from the patient's mouth, and try and avoid stimulating the gag reflex and the vagus nerve in the back of the throat. All right. Once using an electronic airway or suction machine, always clean, flush it immediately to try and remove anything that may potentially block it up. Okay, now for an unconscious patient, maintaining the airway is quite important. We would want to place the head tilt chin lift maneuver, or for those with a spinal cord injury or neck injury or head injury, we're going to try and use the jaw thrust maneuver. If a patient is breathing adequately, in other words, okay, now pay attention. If a patient is breathing enough to support life, okay, 12 to 20 breaths per minute, regular and strong, not weak, not shallow, not anything else, regular and strong. Anything between 12 and 20 breaths per minute, we place him in the recovery position with postural drainage. Postural drainage is there so any saliva could flow out of the mouth. The airway remains open, and if the patient vomits, the vomit can run freely from the patient's mouth. Always remember to maintain and check your patient regularly. Okay, if an unconscious patient is not suffered trauma, that's what we're going to talk about. Gravity is used to help drain out the mouth. There's a good picture of a patient in a recovery position, head being supported by the hands, airway pretty much open, and anything can drain out the mouth. Airway adjuncts we use mostly for these type of things, 2 primary purposes: open the airway and a pathway for suctioning. It can also be used as a bite block if the patient has a tendency, if they're unconscious, to close their mouth and maybe bite against tubes that are supplying air, things like that. We can use it as a bite block, but that generally becomes part of the EMS procedures, not EMR. Okay, now we use an airway for unconscious patients who are breathing. Okay, we might use the airway for they are in respiratory arrest. But the most important thing is we can't use an airway if they still have a gag reflex in place. If you put an airway in and the gag reflex in place, you encourage the patient to vomit and going to stimulate the vagus nerve at the same time. Oral airway or oropharyngeal airway, OP tube, okay, is designed to hold the tongue forward. It's clenched between the teeth, and the tongue is cradled in the back and holding it forward. Okay. There's a couple of things you need to know about these things. When we place an airway tube in, we first measure it. How do we measure an OP tube? Okay. We check for the angle of the jaw and the center of the lips, or the lobe of the ear and the corner of the mouth. Okay. If we measure the jaw according to those two things, that would be an adequate size. That number one, it would not block the airway because it's too long. Number two, it wouldn't fall into the patient's airway because it's too small. Small or too small or too large could be just as dangerous as sticking an object down the patient's throat and blocking it. Anyway, all right. Definitely speaking, when we put this airway into the patient, we put it in upside down. In other words, the top part of the question mark is pointing towards the roof of the mouth. Once the OP tube is in the correct place, we turn it 180 degrees, cradling the tongue and keeping it forward. Other things to be aware of when putting in the airway adjunct: beware of damaging the soft tissue on the top of the mouth. Or there's a chance of scraping the skin off there, and that piece of skin could be getting into the throat and causing an airway obstruction as well. Okay, we can't obviously force these tubes into the patient's mouth if the patient is suffering from the jaw is clenched, trismus. We can't obviously force the tube into the mouth in this situation. We would have to try and manually adjust the jaw in order to get this tube in. Okay, B is for breathing. Okay, now how do we check for breathing? We always use the term look, listen, and feel. Look to see if the chest wall is moving up and down. Listen for the sounds of movement of air in and out of the lungs as you lower your face towards your side of your face towards the patient's face, and you can always feel for the movement of air on your cheek as it moves in and out the patient's lung. A patient at rest, breathes. Signs of inadequate breathing. Now, these are very important to listen for, okay? Noisy respirations. If you can hear bubbles or things like that, wheezing. Wheezing usually indicates an asthmatic attack or something like that, where the patient can't breathe out properly. If there's water or fluid in the trachea, any sort of fluid in the bronchial, things like that, it records gurgling type sounds. If he has a high-pitched sound when breathing in, like a partial airway obstruction, it's called stridor. Okay. We also want to check for things like rapid breathing, gasping for air hunger. Signs and symptoms of inadequate air is pale blue skin, almost ash color. Use of accessory muscles in the neck and things like that. Exaggerated chest movements. Okay. The most critical sign of respiratory arrest is characterized by the lack of chest movements. In an asthmatic patient, you'd call this a silent chest. There would be no sound of breathing. Okay. There would be no air movement across your face. The story about putting a mirror in front of the patient's face is not as reliable as it seems to be. Okay. We always want to put our face down and feel for movement of air on our cheeks. Okay, against the side of our face. Don't put a feather under the patient's nose to see if he's breathing or not. May be allergic to those type of things. Okay. Inadequate sounds of breathing continued. Causes of respiratory arrest. Obviously, if there's no heartbeat, there's no breathing. it seems like a pretty obvious thing, but people seem to forget. If there's no heart, there will be if there's no pulse, there's very little chance of breathing actually taking part much past a certain point. Always check for mechanical blockage or obstruction caused by the tongue. Okay, vomitus, particularly in a patient in a weak condition, like a stroke patient or an epilepsy patient or something like that, could always cause a blockage as well. Foreign objects in children, babies, that type of thing is always a thing to be aware of. And illnesses and diseases, the things that come to mind would be chronic obstructive pulmonary disease or COPD, asbestosis, emphysema, those kind of things. Other things that could cause difficulty breathing or respiratory arrest, overdose of drugs, poisoning, hypovolemic shock, severe blood loss, electrocution. Please, if you're dealing with an electrocution, ensure that the power has been isolated. If you're dealing with a patient that's been struck by lightning, remove the patient from the area and put him under cover. Before you don't go out with an umbrella in a lightning storm. People don't think about things like this. No? When we check for the presence of breathing and the patient is motionless and begins checking for responsiveness and signs of breathing, if a patient is unresponsive, quickly scan to see if the chest wall is moving. If the chest wall is not moving, we need to do something, and we need to do something quickly. Correct breathing, we can always do rescue breathing. As you perform rescue breathing, keep the patient's airway open. Okay, head till chin lift maneuver. Pinch the nose close, take a deep breath and blow slowly into the patient's mouth for 1 second. Okay, unless you're very well aware or intimate and know the patient very well, always use a mask or something like that to prevent any diseases or anything coming back into your throat and causing you to become ill or in life endangered. Always move your mouth and let the lungs deflate and breathe for the second time. After the first 2 breaths, breathe once every 6 seconds. Okay, so it's 1, 2, and then 1, 1, 2, 3, 4, 5, 6, 2, 1, 2, 3, 4, 5, 6. That is the correct method for rescue breathing according to this program. Now, I would always ensure that we have some sort of barrier between myself and the patient. Most effective and the easiest to use would be a pocket mask or mouth-to-mask breathing apparatus. This enables you to perform rescue breathing without contacting the patient's mouth. There's very little risk of diseases. Now, with the mouth-to-pocket mask, things like this, these things can always be sanitized and reused. It's not a once-off thing, and it can be used on all sides of the patient, babies included. Children's, babies, and adults. You can just turn it around and use it on the baby upside down. Okay, mouth to barrier breathing devices are small enough to carry. So just put it properly in your bag, things like that. Provides only a portion or a certain degree of infection control, but it's better than nothing at all. There's a position of the rescue breathing, mouth-to-mouth resuscitation without equipment. Remember, only do it to somebody that you know very, very well, especially if you may consider or think that the patient has a risk of infection or infecting you for something. Bag valve mask, best deal. Bag valve mask provide a very good seal on the patient's face. If you have oxygen and you're trained to use the oxygen, you can always fill up the bag at the end of the bag valve mask, thus ensuring the patient is getting 100% oxygen every time you pump that mask. It's easy to control the mask, the pumping. It takes practice, though, to actually get the correct seal of that mouth mask on the patient's face. Okay, there's a good example. 2 men doing it. You can also do it with 1 person using a CE grip. C, index finger and thumb, or forefinger and thumb forming a C. Okay, the remaining 3 fingers causing an E. Okay, the 3 fingers underneath the jaw, and the C part of the grip applying pressure to the mask under the patient's face. Those 3 fingers underneath the jaw can be used as a method of lifting the jaw and opening the airway. In fact, it helps to get proper seal on the mask on the patient. Okay, airway and breathing. Obviously, airway, we check for responsiveness. Are you okay? If the patient answers you, you know two things. Number one, they're alive. Number two, they have an airway that is capable of carrying oxygen backwards and air backwards and forwards. If the patient is unresponsive, always get help. Okay, always get help. If you're unsure, get help. If the patient is on their back, scan for signs of breathing. If there's a pulse and there's breathing, place the patient in their recovery position. If a pulse is present, but the airway is closed, try something like the head tilt chin lift maneuver or the jaw thrust maneuver. Always a good idea. Check for any secretions, vomit, solid objects, anything found in the patient's mouth. If the patient is unconscious, try and do a finger sweep or suctioning. Remember those rules of suction. Not too long, only what you can see, and only while withdrawing the catheter. Hold and maintain the airway using oral airway, oropharyngeal airway, or OP tube. Okay, check for the presence of while breathing while checking for responsiveness. Okay, correct lack of breathing, and always ensure the baseline vitals for breathing, 12 to 20 breaths per minute in an adult, regular and strong or full. Rescue breathing for children. Children are smaller and will not have to use so much force to open their airways. Okay, and tilt the head, tilt chin lifts, things like that. Give one rescue breath every 3 seconds, 2 to 3 seconds, up to 20 seconds per breath. About every 20 to 30 seconds. So it's just for a bit, and then every 20 to 30 seconds per breathing minute, 20 to 30 times a minute. Okay, remember in an infants have very small lungs. There's no force at all exerted in blowing. Basically, what you can fill in your cheeks, you're going to try and deliver to the patient. Causes of airway obstruction, as I said to you earlier, the most common airway obstruction is caused by the tongue. Simple maneuvers like head tilt chin lift or a jaw thrust may open the airway. Most common foreign object obstruction it causes is obviously food. People don't chew properly in a hurry to swallow. The food may be dry, especially processed food, and it gets stuck halfway down the throat. There's minimal or no lubrication. There we go. Number A, tongue blocking the airway. Number B, an injury to the throat, direct trauma to that area, swelling, could be an anaphylactic shock or something like that, anaphylaxis, or a foreign object in the throat itself. Okay, if the airway obstruction is there and are you choking, ask the patient, are you choking? They may be able to reply. If they can reply to you, then it's not completely blocked. If the patient can't speak or cough, the airway is completely blocked. You have moments to try and sort this thing out. In a mild airway obstruction, a patient could normally gag or cough or vomit or something, and the patient will be able to speak, but with difficulty. In all cases, the patient will probably be grabbing their throat. This is a very common sign of airway obstruction. If it's a mild airway obstruction, encourage the patient to try and cough. Okay. If the patient cannot expel this thing, we need to start arranging rapid transport to hospital. Okay. If this thing is now a severe airway obstruction and the patient cannot breathe in or out, speech is impossible, we look for other symptoms including poor air exchange, increased breathing difficulty, a silent cough, loss of consciousness within 3 to 4 minutes. It might not even take 3 to 4 minutes. Treatment involves abdominal thrusts. But obviously, before we're going to do abdominal thrusts, we're going to try and apply some drills to remove these airway obstructions. If the patient is unconscious, stand behind them and deliver abdominal thrust. I would first, if it was me, try and do 5 back steps in an upward position, in an upward direction, and try and release the blockage that we're still looking at airway obstructions. If it's a child that has an airway obstruction, Tilt the head back past the neutral position, see if you can see anything. If the child becomes unresponsive, CPR for 5 cycles before activating the EMS. If a child is choking, you can always lean them forward, apply 5 back steps to the middle of the back in an upward movement, upward focus, trying to force the thing out. If there's no airway coming out, use a one-hand Heimlich maneuver or abdominal thrust. If an infant has got an airway obstruction, if an infant has an audible cry, the airway is not obviously completely obstructed. Okay. If it's unable to cry or there's a complete obstruction, okay, then we will do something else. Airway obstruction in an adult. Okay. In all cases, especially for infants, if a combination of back steps, 5 back steps, holding, supporting the head, okay, turning the baby over, the infant over, holding, supporting the baby, 2 fingers, center of the chest, 5 compressions, 2 centimeters deep, okay, at a rate of 100 to 120 compressions per minute. If they're still not doing it, we're going to continue and we're going to do more serious interventions. We're going to start doing CPR. In all cases, when the patient becomes unconscious, CPR. When ABC fails, CPR is the next way to go. Oxygen. Let's have a look at oxygen quickly. Oxygen, if you try to do so, all oxygens are compressed, cylinders are compressed around about 2,000 pounds per square inch of oxygen. Just on a side note, which turns it into a missile if it becomes damaged. 2,000 pounds of pressure is a lot. Portable air cylinders size D or E would last about 20 minutes on a high flow rate, depending on the flow rate. Okay. If you need to have a longer period of oxygen, one would consider lessening the flow rate to increase the length of oxygen delivery. If we take a look at the top of this portable cylinder, we will see that it has a regulator or flow meter. Okay, these things are attached to the cylinder. They have 2 indexing pins and a rubber O-ring. Okay, when we've thumb tightened the regulator in the correct place, okay, we will open the flow rate of the regulator. Can be just 2 liters per minute, half a liter per minute, up to 15 liters per minute. And that gas seal, the gasket supplies, that O-ring supplies a good tight seal. Before we open the actual tap, we're going to open the regulator on the side. 1, 2 is quite enough, and then we would open the tap on top. The reason why we're opening the tap on top is we're trying to gauge how much oxygen is in the cylinder, number 1. Number 2 is we don't want to blow the diaphragm inside the regulator, so we always allow the air to pass directly through. Once we are satisfied that the air is now passing through the cylinder or through the regulator, we then close the flow rate to 0. Okay, we now are going to listen to the cylinder to see if there is any air escaping on the sides and things like that. Maybe the O-ring or the seal is not in the right position, or it's been damaged. We don't want to lose oxygen unnecessarily. We need to try and correct that. Also, must be sure that there's no grease or oil or things like that on that point of connection in case of causing a fire because of air escaping or things like that. Grease and oils always explodes under pressure, so we need to be careful of those type of things. Once we're satisfied that there's no leaking air, we then can now proceed to applying the oxygen to the patient. You will see on the gauge that there should be about 2,000 pounds of pressure in a freshly thinned oxygen cylinder. We will then go and we will select a different type of mask, okay, to put onto the oxygen cylinders. Nasal cannulas and face masks. Nasal cannulas most commonly seen in hospital. People with chronic obstructive pulmonary disease. Those are those 2 little pipes that fit into the nose, over the ears and under the chin, feeding to the oxygen cylinder. Please note that these cannulas only support a low dose oxygen, We can never overdo it on these type of things. You must remember there's a formula that is used to determine the percentage of oxygen that the patient will receive. That is definitely 4 times the flow rate plus 4. Okay, so if the flow rate is 4, it's 4 times 4 is 16, plus 4 is 20% oxygen. As I said, generally used with people with need just supplementary oxygen to help them to survive or to live a better life. Okay, other type of devices obviously is a face mask. It's a rigid mask just used to put oxygen on. There's going to be a certain amount of oxygen lost, so the percentage of oxygen the patient will be getting will not be a full 100%, it'll be slightly less. Non-rebreather masks are most common used by emergency systems. They have a bag on the bottom which can be filled up with oxygen, thus delivering a higher percentage of oxygen to the patient every time they breathe in or out. There are 3 things that will determine the percentage of oxygen the patient will receive. Obviously, the flow rate of the valve. If it's turned on to 2, it's going to be a low flow rate. If it's turned on to 15, it's going to be a very high flow rate of oxygen. Okay, the type of device used, remember some masks can only go up to a certain percentage because they have a constriction or a baffle in there, which only allows so much air to flow through, so much oxygen to flow through the mask. Thinking of a Venturi mask, pink one would be about 40% flow rate, 8 liters per minute. A yellow one, 4 liters per minute, 28% oxygen. And then obviously your bag valve mask or your non-rebreather mask would give you about 90%. The other one is the seal on the patient's face. The tighter the seal, obviously the higher the percentage of oxygen that is delivered through that device. Safety considerations when dealing with oxygen. Obviously remember that if the vehicle is oxygen cylinder in the vehicle, it must be stored safely at all times. If there is spark, heat, flames, oily substances, it could turn into a serious fire very, very quickly. Remember, oxygen supports combustion. Okay. And pressurized oxygen cylinders can cause explosions if damaged. Oxygen should always be kept in sturdy cases and kept safe. Okay. Supplemental oxygen, always remember to replace the flow meter, the stem with the 2 indexing pins, tightly attach them when the regulator to the cylinder, turn cylinder valve 2 turns clockwise. Okay, let's check the gauge, the flow meter. Okay, adjust the flow meter to the desired liters per minute flow. When oxygen begins to flow, place the patient on the mask on the patient's face or the nasal cannula into the patient's nose. All right. Always remember, don't switch off the oxygen until the patient's mask has been removed from the patient's face. Okay, there's nasal supplement, nasal cannula, 1 to 6 liters per minute, up to a concentration of about 40 liters per minute, 40% oxygen, and you adjust the flow rate, usually between 20 and 24 liters per minute. Non-rebreather mask, usually a high flow rate, can deliver oxygen concentrations up to 90%. Remember, told you that the seal of the mask on the patient's face could be the reason for the loss of 10% worth of oxygen over here. Okay, when would we use these type of things? Obviously, if the patient is have a life-threatening condition, we would obviously pump up the oxygen. 10 to 15 liters per minute would be acceptable in this type of things. Shortness of breath, severe chest pain, carbon monoxide poisoning, or CO poisoning, congestive cardiac failure, signs and symptoms of shock, definitely anaphylactic shock. Okay, those would definitely call for high flow rates of oxygen. Medium flow rates of oxygen, things like pneumonia, bronchitis, general difficulty breathing, things like that. Supplemental oxygen must be used carefully. Your team should remain safe at all times. Remember, safety first. You will need to have additional training on how to set up and use oxygen cylinders. I would suggest complete refreshers every now and then on how to use these things. Okay, pulse oximetry. Certain of the ECG machines used in the ambulances come with a pulse oximeter built into it. Otherwise, a simple little pulse oximeter can be purchased and placed on the patient's finger. Now, this is very good to see what the oxidation, what the percentage of oxygen is in the blood, oxygen saturation level, or SpO2. Okay, we put it onto the finger. It also sometimes monitors the heart rate and gives you a good feedback on pulse. But sometimes there are a few things that will make this thing not work properly. Firstly, oxygen always needs to be between 94 and 100% oxygen saturation level. Things that could cause oxygen to become less than that would be things like asphyxia or CO poisoning, difficulty breathing, all those type of things. Airway obstruction would all cause a decrease of percentage of oxygen. Okay, stopping breathing would also cause that type of thing. Anywhere below 90%, we would really start to be very concerned about the patient. 94 to 100 is your average for people. The pulse oximeter cannot tell you what's wrong with the patient, but it can help you recognize certain problems, okay, and help you in the determining the treatment of your patient. Okay, now when it doesn't work, when the patient is wearing nail polish or has dirty fingers, when it is very cold outside and the blood is not flowing to the skin, when the patient has lost an excess amount of blood, usually hypovolemic shock, if the patient is experiencing carbon monoxide poisoning, it could be cyanide poisoning for that matter too, okay? If the patient is anemic, will also have effect of these things. There's no machine that can replace a very good, careful patient assessment. Okay, gastric distension or vomiting. Okay, when we do assisted breathing, when we do CPR, there's always a chance that the air is going to be forced into the stomach instead of the lungs. Things that would be cause this would be like blowing too hard, too fast, not allowing the chest to recoil properly before we blow again. Okay, if the airway isn't open properly while we're doing resuscitation, all these things would increase the chance of the patient vomiting. Now the air goes in, but it's got to come out. And if this happens, we need to make sure that the patient doesn't choke on this vomiting. Always remember that if the patient has loose dental fittings, to remove these things, because these could also become a blockage and cause a problem in breathing. Hey? Always keep the patient's dentures in a safe place though. If your patient is trapped in a vehicle or has difficulty breathing while in a vehicle, we need to always try and support this patient. The patient is lying on the floor on the seat, we need to possibly just support the head, because we must always be aware of the possibility of a spinal injury, which could add to the difficulty in breathing. When we approach a patient or we approach a vehicle, we always approach the vehicle from the front so the patient can look forward, doesn't have to turn their heads. Once we've acknowledged the patient has seen us, we would move to the side of the vehicle. Okay. And while we're on the side of the vehicle, we lean through the window or we access from the back seat, supporting the head and neck and keeping the airway open. Okay. Remember, if you consider the patient may have a spinal injury, we would always try and use some sort of a soft collar just to help support that head and stop it from moving. If the patient is seated or semi-reclining, grasp the patient's head with both hands. Put one hand over the patient's chin and the other one on the back of the head and support it. So that's one under the chin, one on the back of the head, support that cervical spine. His life may depend on it, and you may be doing a proper job. There's a good position, good technique to use. Remember, if you need to turn the patient's head into a neutral position or align it in a neutral position, if the patient starts having signs and symptoms of tingling or loss of movement or feeling in a limb, then it's definitely time to stop what you're doing and reassess the way you're doing it. Okay. Technique of holding the head and things like that is the several advantages. You do not have to enter the automobile. You can actually be from outside handling it. If you can't get to it, then you may have to enter the automobile. You can easily monitor the patient's carotid pulse and use breathing patterns by using your fingers. This technique stabilizes the cervical spine and it opens the patient's airway